good evening, everyone. Thanks for coming along after what was no doubt another busy work day for everyone. My name is obviously Cameron Collins, podiatrist and co-director of Fungal Nail Solutions in New Zealand. We operate 3 clinics in Tauranga, Hamilton, and Auckland as well. And this is basically a 3-part webinar series. This is obviously number 1 of 3, where I basically plan to share my clinical expertise on best practice guidelines for effective treatment and diagnosis of onychomycosis or fungal nail infections. So tonight's webinar will explore the importance of accurate diagnosis and also evaluate diagnostic techniques for onychomycosis. We're going to learn a little bit more about what to look out for during clinical examination and understand when confirmation with mycological testing is needed or required. And, accurate diagnosis is important since the treatment of onychomycosis can be long-standing, can be expensive, and can be accompanied with adverse effects or events, especially when we start to look at the prescription or use of oral medication, your terbinafines and your itraconozoles. Additionally, as clinicians, we go into health because we want best outcomes for our patients. And in order to do that, we really need to ensure that our patients are on the best treatment protocols from day one and try and minimize or mitigate any sort of trial and error type approaches. And on a more personal note, and I'm sure a lot of us here do use the Lunula cold laser, if we are going to promote the potential success of the Lunula laser within our clinics, we do need to ensure that the right candidates are being prescribed this particular course of treatment. So simplistically, plan of attack tonight, we're basically first going to look at dermoscope findings and what to look for in our visual examination. We're then going to have a look at some common onychomycosis mimickers and how to identify them as differential diagnosis. Thirdly, we're going to look at the importance and also the place of more formal lab testing, so microscopies and culture. And then we're going to wrap up with basically my concluding thoughts, some questions, and hopefully some discussion. And obviously, I'll do my utmost best to try and answer any questions that sort of come my way. Finally, I've basically tried to create quality content rather than quantity. So I certainly won't be keeping everyone for a full hour, hopefully, but I'm hoping that everyone can at least leave this evening with a few clinical gems. So without further ado, let's kind of get started. So to kick proceedings off tonight, one aspect that can help us a lot in obtaining an accurate diagnosis is through the use of dermoscope, or if we don't have one in our clinics, even more simplistically, just a visual examination of the involved nails. So clinically, what I've found is that there's sort of 3 dermoscopic findings that are pretty much exclusive for onychomycosis or fungal nail infections. So observations that I'm looking for any patient who attends my clinic with a suspected fungal nail infection is number 1, a jagged proximal edge with spikes of the onycholytic area. Onycholytic area being the lifted nail plate away from the nail bed. Longitudinal striae, which we'll talk to very shortly, and then a distal irregular termination or a ruin-like appearance. Now, obviously, some clinical subtypes of fungal nail infections, such as your proximal infections, your superficial white infections, and also your endonyx infections, do have other clinical features, but I didn't want to leave us going for too long today. So this might be more of a discussion in another webinar on another day, but obviously happy to have a chat to some of us outside of this webinar if people want to find out more detail in these areas as well. So the first one, really what we're looking at is that jagged proximal edge with the spikes of the onycholytic area, which we can see quite clearly in the picture to the left of your screen. So in this pattern, the proximal margin of the onycholytic area has a jagged edge with sharp longitudinal whitish indentations directed to the proximal nail fold, which effectively form those spikes. Now, this differs quite significantly from an onycholytic nail, which tends to have a more uniform or symmetrical proximal edge. So really what we're looking for here in our examination is whether the proximal discolored nail is jagged and spiked, suggesting of more of a fungal nail infection, or whether the proximal nail plate is uniform, indicating more of an onycholytic nail plate. Now, this particular type of presentation is characteristic particularly in our total dystrophic onychomycosis, but also our distal lateral onychomycosis as well. The second finding that we alluded to was the longitudinal striae. So again, picture to the left. In this pattern, basically what we're looking for here is different colors of striae that can be observed in the onycholytic nail plate. And we can see here that the colors range from sort of white to yellow, but we can also get orange and brown. And these differentiation in colors are basically reflecting the colony scales and subungual debris, and also their progression along the nail plate. Now, again, if we think back to a pure onycholytic nail, we won't tend to have these changes in color running through the nail plate. Now, this pattern in particular is more characteristic with our more common distal lateral onychomycosis, which no doubt everyone sees in the clinic quite frequently, not so common with our total dystrophic infections. But what we do see in our total dystrophic infections quite commonly is this kind of distal irregular termination or ruin type appearance. So this pattern is basically characterized by indonate areas of the ventral portion or the bottom portion of the nail forming a keratosis aspect that corresponds with the accumulation of dermal debris and basically distal pulverization or obliteration of the distal nail edge, which is characteristic of thickening of the nail plate in total dystrophic onychomycosis. So basically, in a nutshell, at the distal nail plate, we have no clear border, and the nail bed surface is filled with dermal debris, which basically gives it this ruin type appearance. And probably quite an easy way to visualize that is by discussing it as a ruin appearance. It's also really important to note, though, that the absence of clinical distal longitudinal striae is present in this photo. So we don't have that distal longitudinal striae. And this is kind of explained more by our advanced level of fungal invasion. So once we get more into those total dystrophic advanced infections, we don't tend to see that longitudinal striae so much. We tend to see more of this ruin type appearance or this distal irregular termination. So simplistically, when we have an infection in front of us, if we have a linear onycholytic edge at the proximal border, so again, a linear onycholytic edge at the proximal border, we can basically exclude onychomycosis in about 80% of cases. However, if we have a jagged edge at the proximal border with the presence of spikes, plus or minus those longitudinal striae, and as discussed in the previous slide, this does depend a little bit on the severity, we're much more likely to have a fungal nail infection presenting in front of us. However, two other important visual findings that we must consider that don't quite fit into this mold, which probably account for part of that 20% that we can't exclude with a linear edge on dermoscope, are sort of well-defined opaque white islands on the external nail plate, which are really common with our superficial white infections, but also sort of brown, gray, and black pigmentations, which basically present as longitudinal lines or structureless discoloration at times, which are commonly found in our fungal melanochere, which again is something that we can talk about in a future webinar if required. However, in addition, there are a few other observations that we do want to make note of when examining an infection, especially when we start understanding when cold laser might be suitable or might be a suitable adjunct or in fact replacement to more of our oral or topical therapies or clearer nails or photodynamic or whatever else you use in your clinic. Now, although I'm going to dive into more of these in our next webinar as we start to look at patient expectations and prognosis, I would like to make mention to them at this stage whilst we talk about our physical examination and what we're looking out for. So the first one is a lateral edge involvement. So patients that have a lateral edge involvement tend to be far more difficult to treat. Prognosis tends to be worse. Extensive onycholysis. So basically in these cases, if we have extensive onycholysis, it's pretty much preventing a topical drug from being able to reach the nail bed. And it also can reduce the delivery of oral antifungal agents from the nail bed to the adjacent ventral nail plate, as there is an insulation layer of air between the nail bed and nail plate. And I have a lot of patients that come through my door who have had oral medication that hasn't worked because of this extensive onycholysis that presents with them. Dermophytoma or spikes. So basically what the dermophytoma is it's basically a densely packed clump of dermatophyte hypophae which is basically thick-walled and somewhat abnormal looking, and basically gives us sort of a big buildup of paste that forms underneath the nail plate. And basically what this does is it creates a really tightly packed space of fungal elements, which, as you can imagine, it means that the concentration of the antifungal agent that's being delivered to that site will be lower based on the higher concentration of fungal within that surface area. Nail thickness and also extensive hyperkeratosis, or that buildup of dermal debris. So it's pretty logical that it can be difficult to treat patients with thick nail plates or subungual hyperkeratosis, as it's more likely to be difficult for the drug to reach sufficient concentrations in that sort of thick hyperkeratotic nail. Matrix involvement, so extension of the infection into the matrix, is generally accepted as a negative prognostic factor, and no doubt plenty of us using the laser in particular, once we start getting matrix involvement, the prognosis gets lesser and lesser. Nail involvement, pretty big one. So the percentage of onychomycosis involvement is often considered to be an important prognostic factor. And I use it a lot in my clinic to determine the type of treatment that we are going to use for a particular patient. Now, generally speaking, with a topical terbinafine, for example, the cure rates were higher in patients with less than 40% involvement. And this factor may be of greater importance when we're starting to think whether topical drugs are going to be used or not. But generally speaking, once we start getting a nail plate that involves more than sort of 35 to 40% of the nail plate, we know that we have a slightly bigger mountain to climb in regards to long-term prognostics for a patient. And the last one that I just want to touch on from an observational perspective is we want to just have a look at other diseases involving the nails. So if there's a coexisting nail disease indicated on our visual examination, such as psoriasis, which we're going to talk to shortly, the response to treatment may be poorer. But really for now, this is just to get you thinking about the types of things that we're looking at beyond of whether a patient does have a fungal infection or not. But all we really want you to get out of this at the moment is that there are 3 dermoscopic findings exclusive for onychomycosis that we must remember, okay? So basically, you've got your jagged proximal edge with spikes of the onycholytic area, we've got the longitudinal striae, and we've got the distal irregular termination, or the ruin type appearance. And these 3 characteristics are far more common with your distal lateral infections and also your total dystrophic infections, which are really, really common presentations that come through our clinic in particular. So if we've completed our visual examination and it doesn't really clearly rule in a fungal nail infection, we must kind of start considering our differentials. So onychomycosis tends to be the diagnosis of onychodystrophic nails in about 50% of cases. However, there are a variety of other etiologies that may be causing onychodystrophic nails. These other conditions may mimic onychomycosis in their presentations and must be excluded before initiating any antifungal treatment to make sure that we are getting the patient on the right treatment and that we're getting the best clinical outcomes for them, again, from day one. But also, if we tell our patients who present to us thinking that they have a fungal infection, and we as the clinicians tell them that they don't have a fungal infection, I can almost guarantee that they're going to say, well, if it's not a fungal infection, then what is it? So not only do we have to be able to differentiate, but we also have to be able to give our patients answers as to what it is, but also how we go about treating it. So on that note, what could it be? So differential diagnosis includes nail diseases that cause subungual hyperkeratosis and or onycholysis, which are obviously 2 very common characteristics of a fungal nail infection. So as we can see in the table here, I've tried to break it down reasonably simplistically and talk to a few conditions tonight. But basically, nail conditions that are going to cause subungual hyperkeratosis and onycholysis, which happens in a fungal infection, are your psoriasis, contact dermatitis, and your nail bed lichen planus. Your onycholytic characteristic, which will present in your traumas, your yellow nail syndromes, and your nail bed tumors. And then subungual hyperkeratosis without onycholysis, pachyonychia congenita, which is a fairly rare condition, which we're not going to talk too much about tonight. But again, just getting us thinking about when we have subungual hyperkeratosis, but we don't have that onycholytic edge, potentially what could it be? Now, although we're not going to really discuss these pathologies in great depth, I think it's really important for us to understand what we're looking for when considering differential pathology. So starting off with nail psoriasis, which is a fairly common one that comes through the door. So it obviously presents with clinically with pitting, onychomycosis, with obviously redness around the borders, salmon patches, subungual hyperkeratosis, and splinter hemorrhages. So as we can sort of tell by some of those characteristics, you can see why patients may think that they have a fungal infection, but also for clinicians that don't know what we're looking out for, we could also see how they could be presenting with what you think is a fungal nail infection. So the most common change that we see in nail psoriasis is the pitting, generally speaking, in the early stages, basically where we have small depressions of less than 1 mm in diameter, which is seen on the surface of the nail plate. So if we start to see this pitting type presentation in our patients, we should be starting to think that this might not be a fungal nail infection, despite the presentation of your onychomycosis and your subungual hyperkeratosis. Now, a salmon-covered patch may also be seen beneath the nail bed, and this basically resembles an oil drop, all right? And this oil drop sign is basically the most diagnostic feature of nail psoriasis when they do present. And the last thing I just wanted to make note of, which is less common, but your splinter hemorrhages, which basically appear as a linear, thin, deep red to black line in the distal nail. Contact dermatitis. So contact dermatitis frequently affects the nail bed, basically as chemicals penetrate through the nail plate, causing subungual inflammation with onychomycosis, again, very common with a fungal infection, as well as that subungual hyperkeratosis, again, common in your fungal infections. This can be very severe in patients with contact allergies to acrylic nails. And on that note, we see far more of these present in the fingernails rather than the toenails. And contact dermatitis secondary to acrylic nails is something that we see through our practice all the time. The other thing that we can see is splinter hemorrhages, just like in psoriasis, which we discussed in the previous slide. And basically the diagnosis is suggestive of the presence of periungual erythema, or the redness around that skin, as well as bowlines, which are basically horizontal ridges or dents that run through the nail plate itself. Lichen planus, which is a chronic inflammatory disease, so basically commonly involves the nail matrix, which causes longitudinal grooves and fissures, as well as progressive thinning and distal splitting of the nail plate. It also commonly affects the nail bed, causing subungual hyperkeratosis and onychomycosis. Hopefully we're seeing a trend here that all of these conditions are presenting with similar characteristics, but a few different characteristics as well. And particularly in the toenails with this condition, it often causes yellow discoloration and thickening and gives it a yellow nail syndrome-like appearance, which we'll talk to in a second. Trauma, so again, another really, really common one that we see come through the clinic. Signs of trauma may include a mechanism of injury, but as we're well aware, sort of micro trauma is another common reason why we may have a nail plate present like this. Onychomycosis, subungual hyperkeratosis, abnormalities of the nail plate, changes to the hypernychium, ingrown toenails, changes to paronychia, and also onychomycosis, which is basically the proximal separation of the nail plate. And we may or may not have a subungual hematoma, which presents more with your mechanism of injury and more drastic traumas. And it may be frequently colonized, these nail plates, by microorganisms that basically produce pigments mimicking onychomycosis. And I think there's a lot of sort of changes that occur with these trauma nails, and a really common presentation for us to see in clinic. But I think the most important thing for us to remember with these types of presentations, coming back to our dermoscope findings, is that the proximal border of the onycholytic area is sharp. And so if we look at this picture compared to our proximal jagged edge with our fungal infection, this one appears much more sharp and uniform rather than having that jagged edge, which is far more common with your fungal nail infections. So because it's not jagged or including spikes, it's much less likely to be presenting as a fungal nail infection and more of an onycholytic nail secondary to trauma. Yellow nail syndrome. So this is quite a rare disorder that presents, and we have seen it a couple of times in clinic, and that's why I've kind of popped it in the slides today. But it's associated with lymphedema and chronic respiratory disease. So it's basically characterized by a triad of clinical features, which makes it quite easy to diagnose. Yellow nails, lymphedema, and chronic respiratory involvement. So some sort of pleural effusion, bronchiectasis, sinus infections, chronic coughs, and chronic lung infections. And so we need 2 of the 3 features must be present in order to make a diagnosis of yellow nail syndrome. But again, not that common, wouldn't stress too much about it. The last one I just wanted to touch on, but I won't go into great depth about it, is your subungual tumors. But I just want us to be really mindful that warts, exostosis, squamous cell carcinomas, and subungual melanomas can present very similar to that of a fungal infection, and just pathologies to keep in the back of our mind when patients present to us. So in a nutshell, to summarize these key points, in general, onychomycosis is unlikely when all toenails are infected, fingernails or both hands are affected, or we have subungual nodules starting to present. So if we have any of this sort of stuff starting or if we're starting to think about this stuff coming through, we should be having alarm bells, red flags, thinking about potential differentials. So with that psoriasis, we're looking for the pitting predominantly, your salmon patches, some sort of skin or scalp involvement, and some sort of joint enlargement or pain. With your nail bed lichen planus, you're basically looking for signs of nail matrix involvement, which causes longitudinal grooves and fissures, as well as progressive thinning and distal splitting of the nail plate. With your nail tumors, we're utilizing your ABCDF guidelines, and we're also more so looking for brown and black colors with irregular lines. Contact dermatitis, usually involving the fingernails. We usually have some sort of periungual skin, so the skin around the nail plate is frequently affected and inflamed and red. And also we want to have a look at the observance of bowlines, or those horizontal lines running through the nail plate. Traumatic onycholysis, so we're looking for podiatric or biomechanical abnormalities, so your overlapping toes, etc. But most importantly in these cases, we are looking for the proximal onycholytic area, which should be sharp rather than jagged. And finally, you get yellow nail syndrome. So we're going to have pretty stunted nail growth. Mostly the fingernails will be affected. And of course, we're being observant for that lymphedema or that chronic respiratory illness. So final thoughts on mimickers or differential diagnosis before we move on. We must consider mimickers as unlikely to be onychomycosis when all toenails are involved, all fingernails are involved. Onycholysis is not associated with a subungual hyperkeratosis, or the proximal border of the onycholytic area is sharp. So if we take anything out of that, if we start ticking any of these 4 points, we really need to start be thinking about what differential diagnosis or mimickers might be presenting in front of us on our chairs. So after all of that, if we're still sitting on the fence about whether our patients present with a fungal nail infection or not, it may be time to consider more formal testing either in-house in the clinic or outsourcing it to a lab. So microscopy, or looking at a nail under microscope, or growing cultures certainly can be a useful adjunct in providing a comprehensive assessment at particular points in time of a patient's journey. So firstly, we must understand when testing might be appropriate. So in my opinion, testing should only be performed when it may influence our clinical decision-making or help in the patient's journey. And I think fundamentally, we want to make that patient's journey as easy as possible. So 3 sort of key points that I think about when I think about whether testing is appropriate or not is when our visual examination of the involved nails is not suggestive of the triad of fungal nail characteristics that we talked about at the start of this webinar. So we don't have a proximal jagged edge, we have no longitudinal striae, or we don't have that ruin appearance. So because those are pretty telltale of fungal infections, if we don't have them, but we still have second thoughts as to whether we have a fungal infection, this might be a reason we test. to determine the species of fungi. So whether we have a dermatophyte, whether we have a non-dermatophyte, or whether we have a yeast infection. And the reason we might want to find this out is to allow more targeted and more effective oral, but also topical treatment as well. So looking at oral, obviously, dermatophytes are used to bidafin quite commonly, but our non-dermatophytes and yeasts are used with itraconazole quite commonly. And as we're well aware that it does have impacts on the liver in particular, and it does get a few patients wound up, it is important that if we are going to put patients on these drugs, we make sure we put them on the right drug in the first place. Again, gold standard treatment from day one. And the third reason why I might send someone to the lab after the initial consult is when a patient's failed previous and comprehensive treatment protocols. So someone coming into me and saying that they've done topical for 2 or 3 weeks in my head is not a comprehensive treatment protocol. But when a patient arrives into my clinic having already undergone extensive oral therapy or even laser therapy, for example, and they've failed, we really want to understand why a patient has not responded to mainstream treatment before we start trying other things. Take a step back before we take a step forward. We're starting to think of questions like, is it because it was never a fungal infection in the first place? Good reason to test. Or is it because there are multiple different colonies or subspecies present? We know that these are going to be a lot harder to treat when we have a combination of colonies present. We also know that yeast and non-dermatophyte infections are more challenging to treat. And is that the reason why we haven't had the response that we wanted? Answering these sort of questions may help us create better long-term treatment plans moving forward and better help manage patient expectations. And I think that's a really, really important part of it, managing those patient expectations. And the more certain we are as clinicians, the better we can manage those expectations for the short, medium, and long term. So before outsourcing a clinical test to a lab, I'll usually consider an in-house test first. So at Fungal Nail Solutions, we utilize the Diagnostic test kit. However, I also understand that ReaCare distribute the in-tray DM, which honestly, I don't have a lot of experience with. But both of these kit tests basically are testing for the presence of dermatophyte infections, not non-dermatophyte, not yeast, but dermatophyte infections. And dermatophyte infections make up about 85% of toenail infections. So if this test returns a negative response, but I'm still convinced an infection may be present, I may refer to the lab for testing of yeast and non-dermatophyte infections, which I'll talk about shortly. So we must understand the limits of these tests, but they can also be incredibly useful. Now, reasons I would refer to the lab directly without performing an in-house test first, and normally we would perform a diaphragm test on most of our patients that come through the door, but when I wouldn't would be when fingernails are involved, as these tend to be far more likely to be yeast infections, which I know are going to return a negative response on my diaphragm test kit. And also when a patient attends my clinic having failed a comprehensive treatment protocol. Now, predominantly when a patient comes in, has had 6 months of terbinafine medication, has failed, as this either indicates that we have a mixture of subspecies or we have a yeast or a non-dermatophyte infection, which again is going to return a negative diaphragm test. So I'm not going to spend the patient's money unnecessarily. So I think it is really important to have these tests in our clinic, but I also think it's important to know the limits of these tests to ensure that we're not wasting patients' time and money. But I just thought I'd throw this slide out in for good measure so that we can fully appreciate how effective these in-tests can be for people that aren't potentially using them. These save the patient both time and money when used correctly if a dermatophyte infection is involved or suspected, but it can also be a really good upsell to our clients in regards to on charging this cost to the patient. And if we think about sending a patient to the lab, either if you can do it yourself, fantastic, but they've still got a lab test cost associated with it. And if you have no ability to directly send someone to the lab, then they've got a GP fee and then they've got the lab fee. So it does end up getting quite costly. So if we can do it in-house, fantastic. Now, these test kits in particular have a sensitivity of 98%, a specificity of 88.2%, an accuracy of 97.2%, a negative predictive value of 78.9%, and a positive predictive value of 99%. So all in all, it's a pretty good in-house test to be able to offer to our patients again, when we suspect a dermatified infection may be present, okay? However, if we don't have an in-house test or in-house tests are not appropriate, referring a patient to the lab can be very, very useful. So let's take a closer look at this process. So firstly, understanding microscopy. So microscopy is more sensitive than culture when diagnosing filamentous fungi. So basically in areas such as the toenails and feet, where dermatified infections are the most likely pathogen, a positive microscopy is diagnostic, and a negative microscopy has sufficient negative predictive value to make a dermatified infection unlikely. Basically what I did is I took some data analysis performed at the local lab that we use here in Hamilton, and they found that a negative microscopy had a negative predictive value of 92% in excluding fungal nail infections of the dermatophyte kind. Pretty good statistic. Microscopy for fungal elements was approximately 3 times, and I'll repeat that because I think it is quite important, 3 times more sensitive than culture for the detection of dermatophyte infections. There are several reasons for this, which we'll look at shortly, but this includes things like the quality of the sample and prior antifungal treatment that had been applied to the nail plate, which is likely to impact the quality of the culture results. A negative culture in many of these cases, when we're looking at dermatophyte infections, is likely to be misleading. So we can get these microscopic results back in a week. And if it is a dermatophyte infection, we should have those results back in a week. And we shouldn't really have to wait for a culture, because this microscopic result or finding for a dermatophyte infection, again, is 3 times more accurate than the culture. So in a nutshell, a dermatophyte fungal infection will likely return a positive microscopy. So if you've already received a negative in-house dermatophyte test using a diaphragm or an in-tray DM, educating your patient that their microscopy results are likely to return negative is important. And again, education. If I have a patient who's failed a dermatophyte test in-house using our diaphragm test, but I still am sending the patient to the lab, I'll always explain to them that I'm likely to find that the microscopy results are going to return negative, but really why I'm sending you to the lab today is to get the culture results to rule in or rule out a yeast or a non-dermatophytic infection. So on that note, understanding cultures. So for yeast such as Candida, the opposite applies. A culture is more sensitive than microscopy. So particularly for areas such as the hands and fingernails, where yeast infections are more commonly seen as the pathogen, we would culture if the microscopy is negative to ensure we are not missing infections. Now, I think what's really important to talk about here before I move on, and I probably should have talked about it in the previous slide, is a lot of clinicians get a little bit up in arms when a lab will complete a microscopy but then won't go on and complete a culture. And normally the reason for that is because that microscopy result has come back suggesting a dermatophyte infection, so there's no requirement to go on to the culture. However, culture of a toenail sample will routinely be performed in the following circumstances: where microscopy is more suggestive of a non-dermatophytic mold or yeast, so either we've had a negative microscopy or there's signs under the microscope that we do have a non-dermatophytic mold or yeast infection. So again, if the signs under the microscope suggest dermatophyte, probably won't push on and do the culture. However, when microscopic results are positive, but standard treatments for toenail onychomycosis, particularly with oral terbinafine, have not been successful, they will culture. Therefore, as clinicians, it is so important to ensure that when we provide a lab referral, we include details about previously failed treatment. That really helps people in the lab determine whether a culture will be taken or not. So if you are wanting a culture to be taken, you must just justify, even if we get a positive microscopic result for a dermatophyte, why you're sending a patient to the lab and why you want that culture. So I'll always detail predominantly oral medication and laser, amongst a few other things. If they have failed a good and comprehensive course of that, I will also always include that on the lab form, which is much more likely to get me to get the lab to make a culture for us. However, negative test results. Negative test results do not necessarily rule out a fungal infection. Now, I don't necessarily want to bore everyone to death with this, but I do want us to keep a couple of concepts in the back of our mind if we do get negative findings. And two of these points that I really want to bring to everyone's attention tonight is negative test results are more likely when antifungal treatment has been used prior to the collection. So I would always burr the nail or trim the nail prior to testing in-house using our diaphragm tests. If you test a nail that has already had antifungal treatment straight into your diaphragm or your in-house test, we're probably going to have a lot of residual topical solution on it, higher chance of a negative test result. If I'm sending someone to the lab, I will always burr the nail first and clear away as much residual topical as possible to give ourselves the best chance of better results. I'll also instruct the patient to avoid using a topical solution 3 to 4 days prior to collection. And the second note that I want to make is a delay in the specimen reaching the lab. Now, I've been pushed by quite a few labs to try and get me to take the sample for the patient to take with them. But I'll always avoid that because I think patients are very good at telling you one thing and doing another thing. So if a patient tells you that you're going to go tomorrow, yeah, I'm going to go tomorrow, life gets busy, kids get in the way, sport, whatever, and then they don't get into the lab a week later and take that sample with them, the likelihood is we're going to get a negative result. So I would always push for the lab to take a fresh sample straight onto culture, which is my preference 100% of the time to ensure that we get the most accurate results. But obviously a few other points through there just to think of in the back of our minds when we do get negative test results. So to conclude, correct diagnosis is key to any successful patient outcomes. I truly believe that the Lunula laser is a fantastic tool in our toolkit, but when it is used appropriately. Secondly, understanding common mimickers and being able to rule in or rule out if you are on the fence as to whether you have a fungal infection or not is really, really important. Again, gold standard treatment from day one. All of these other conditions do have a treatment protocol or treatment plan that you can follow, but we need to make sure that we get them on the right treatment plan as much as we possibly can from day one. And finally, there is a place for in-house dermatophyte testing and or lab testing if and only if it is going to change our management plan or influence our treatment planning. And hopefully through those last few slides, I've given some food for thought around when testing might be appropriate, when it might not be appropriate, and what kind of testing we want to be looking for. So just got a few valuable references that I've used to kind of put a lot of this together and resources that I use on a semi-regular basis. So if anyone has any interest in further readings, I suggest you check out some of these articles.